We're going to go ahead and get started. I'm Marilyn Serafini. I'm with the Alliance for Health Reform, and I'd like to welcome you to today's briefing on payment and delivery system reforms in Medicare. So today we're going to be looking at the evidence behind numerous experiments that are going on across the country to pay medical providers based on quality rather than the quantity of services. I'd like to thank our supporter in this event, the Kaiser Family Foundation, and in particular, our longtime partner, Tricia Newman. And I wanted to let everybody know that you can tweet with us live with this event. You can tweet your questions. You may tweet your comments for both the people in the room and also those who are joining us live on C-SPAN. The hashtag is Medicare Demos. And also, if you'd like to access our speaker presentations and you're not in the room with us, you can find them on our website at www.allhealth.org. So I'm going to turn this over now to our partner Tricia Newman, who's going to tell us just a little bit more about why we're here today.
Thank you, Marilyn, and it's great to be here. Before we get started, I just want to congratulate you, Marilyn, and Sarah Dash, wherever you may be, for taking over the helm of the Alliance. We miss Ed, but it is great to see you both, the new co-CEOs, so welcome, and of course you've been here for a while. I want to thank all of you for coming here today on behalf of the Kaiser Family Foundation. I'm excited to be here, and I think we're going to all learn quite a bit as we focus on the progress of Medicare payment and delivery system reforms. It wasn't long ago that people talked about Medicare as a fairly static program, but things are changing pretty rapidly in traditional Medicare. The long-standing concern that the main problem with Medicare is that it only encourages more and more care has really been changing, and changing at a fairly rapid clip as Medicare is instilling more incentives for providers to do more, provide better care, to manage care, and even potentially at a lower cost. So I'm here, as you are all here, to learn more about the progress of these demonstrations. I think it's fair to say that we all have a lot to learn, not just about how they are today, but how they will progress. Sometimes these things do take time, but it is exciting to see so much change happening and so much energy behind the ongoing effort to improve Medicare for the program, but more importantly for the people who it covers. So thank you.
Great. Okay, so I'm going to introduce our speakers. To my far right, we have Christina Bakuti. She's going to kick off today's discussion. She is Associate Director of the Program on Medicare Policy at the Kaiser Family Foundation. And she's held a number of government positions at HHS, the Medicare Payment Advisory Commission, and the Government Accountability Office. Next to her is Marilyn Moon. She's Institute Fellow at the American Institutes for Research. Marilyn is an economist, and she's analyzed the Medicare program in various capacities, including for the Congressional Budget Office. She has also served as a public trustee for the Social Security and Medicare Trust Funds in the 1990s. To my immediate right is Patrick Conway. He's Acting Principal Deputy Administrator at the Centers for Medicare and Medicaid Services, and he's also the Director of its Center for Medicare and Medicaid Innovation, CMMI. You'll hear that acronym a lot today. And CMMI is overseeing the payment approaches that we're going to be talking about today. Eric DeYoung, of course, next to me is Tricia Newman, and to her left is Eric DeYoung. He's Director of Geriatrics and co-founder of the Medical House Call Program at MedStar's Washington Hospital Center. Eric will give us a glimpse of the Independence at Home program that is getting so much attention and that MedStar is planning to expand to its other facilities. To my far left is Jim Garnham, Director of Contract and Payment Innovation at the University of Rochester Medical Center. He leads Rochester's bundled payment program, and he also has a hand in its ACO-like and risk-based models. So we're going to start off at the far end with Christina Bakuti, who's going to talk about the recent work that Kaiser has done and what evidence we have on hand.
Thank you. Let's see. Okay, good. So I'm going to start with just a little context for delivery system reform in Medicare, and then I'm going to go over a very brief summary of 3 of the models and conclude with a few thoughts on ongoing challenges and opportunities. So to get right to context, I'll mention a few items. Although CMS had already been running some new models on delivery system reform, the Affordable Care Act really brought in a large multi-pronged effort for delivery system reform. It created some permanent changes to the way hospitals are paid, for example, the Hospital Readmission Reduction Program. It created the office that called the Medicare and Medicaid Coordination Office, which is looking at ways to align payments for people who are dually eligible for Medicare and Medicaid. And the ACA also established ACOs through what's called the Medicare Shared Savings Program, which we'll get into in a little bit. And the ACA created the Innovation Center, which of course we call CMMI because we love acronyms here in DC. But the CMMI was really marking a significant investment in testing new payment models, and the ACA gave it unprecedented authority to expand models that achieved certain specified performance on quality and spending. I'd also mention that underlying delivery system reform in Medicare was the passage of MACRA, which was the law that repealed the SGR, which was, of course, many former Alliance briefing topics. But MACRA has within it financial incentives for physicians to be paid a bit more if they are participants in what's called alternative payment models. And this will be coming in future years. And so CMS is planning to release some regulations in the near future, some proposed rules on what exactly will be used to define the alternative payment models. So that should be coming out soon. And then a final piece of context is, of course, HHS's overarching goals to shift more of traditional Medicare payments towards value instead of volume-based reimbursement. And perhaps Dr. Conway would be talking about that, so I'm not going to. But I will move on quickly to this slide, which shows on the left-hand side 3 models of delivery system reforms that we cover in the primer that is in your handouts. And I'm going to talk about some of the individual models that are there on the right-hand side. So starting with medical homes, to distill it down, medical homes are really based on the concept that investing a bit more in comprehensive primary care could lead to lower overall spending due to better health outcomes when you invest earlier in primary care. All 3 of the models on this slide here involve care management fees to the medical homes. And the first 2 specifically have a focus on coordinating Medicare care management fees with other insurers like private insurance and Medicaid. And you can see on the map, you can see on the map that that they're clustered a bit for this reason. The lighter blue is the MAPCP model, and that has more involvement with states. You can see then the whole states colored in. And then the orange dots represent the CPC participants, and in those models, CMMI is playing a greater convening role with those insurers. The evaluation reports for the medical homes are starting to come in. I think at this time, net savings are not very high, but more results are coming. And the CPC model is showing some gains in quality, but again, the others are awaiting more results. I'll move on just for a moment to the independence at home model, which is also a primary care model. But of course, we have an expert with direct experience. So I'll just give you a couple teasers that show what's unique about this model. And one is that its focus is on home visits to address the care needs of frail patients. A second unique feature of this primary care model is that it does not involve care management fees, and in fact has within it the opportunity for the independents at home practices to share in savings if they've lowered spending. And then we'll say that early results from independents at home are showing some promising savings. So then moving on to the ACOs, these are entities that have agreed to be held accountable for both spending and quality for the beneficiaries that have been assigned to them. They can contract with hospitals, physician groups, health post-acute care facilities. The model that accounts for the most beneficiaries, by and large, are the MSSP models. They account for about 7 million beneficiaries across over 400 ACOs. The MSSP model with the most beneficiaries is the one that are called Track 1. And in that model, the providers don't take on financial risk with Medicare, but they can share in savings. There are new tracks that are coming up, but perhaps Dr. Conway would mention them, so I won't. Then there's also 9 pioneer models, which are required to take on financial risk. I'd say that while about a quarter of the MSSPs I just mentioned shared in savings as results came out for 2014, about half of the pioneers were able to share in savings. And that model did get certified to be expanded. Then the last little model I want to note is the bundled payment model. Bundled payments, of course, we're again lucky enough to have someone here who can talk about direct experience. So I would just characterize this model as one that focuses on a whole episode of care rather than payments that are made to individual providers for the individual services that they themselves provide. The BPCI demo has 4 different payment models. They're triggered by a hospitalization, but there are many details, so I'm not really going to get into them. But to say that the results are very preliminary. So finally, I'll just close with a few comments on ongoing challenges and opportunities. We see here that, actually I have to put my glass on. CMS has launched to be fair, a large number of payment models in a very short period of time and in a changing healthcare environment. We can note that while we're all sitting here wanting results, Congress, providers, CMS for sure, it takes time. And so there's certainly a tension between what we want and letting these models be fully implemented as they're being tested. I'd say that the ability for CMS to change these models while they're ongoing, based on early results and based on unforeseen circumstances, presents great opportunities and great challenges for the evaluators, certainly. And finally, I'd note that a key consideration that CMS and Congress will be considering as results come in for these models is how Medicare beneficiaries are really faring in these models, and particularly those with high healthcare needs. They're the ones that we think some of these models were designed to help. So let's learn about them in particular. Thank you.
Thank you, Christina. That's actually a great transition because Marilyn Moon is now going to talk to us about how consumers are faring under these models. Marilyn?
Thank you. I'm going to be relatively brief because I may be talking about a one-horse pony here idea, and that is that consumers matter, and you really need to take them into account in these kinds of models. Some of the earliest innovations that occurred and some of the earliest thoughts about innovations really were often done without even thinking very much about consumers. Imagine an ACO that's getting organized, an accountable care organization, that is thinking about steering patients into different other providers and slightly different models and approaches. But the beneficiary often has no idea that they're in an ACO. They may or may not have gotten a letter. They may or may not have known they've gotten a letter. And in many cases, they're not quite sure why the physician is doing that. If it is for good purposes, for both improved quality of care and lower prices, that's all for the better. But you're going to get a lot better cooperation, a lot better engagement and involvement if the beneficiary actually is engaged and knowledgeable about that. I remember when people were talking at an early event I went to about medical homes, which you would think would be particularly consumer sensitive, and people were talking about patient-centered care and going on. And after mentioning patient-centered care, the term patient never arose again in the rest of the conversation, including when someone was asked about it, and the individual said, well, the physicians have the patient's best interests at heart, and therefore they can take care of that problem. I think we need to change everyone's minds and attitudes in the healthcare world. You are not going to change the healthcare system if you have a raft of patients who are heavily resistant to the change. None of us like to change things that we become familiar with and comfortable with, especially when it's something as complicated and uncomfortable and important as healthcare. So it's very important to get people on the same page. AIR, where I work, did a study a number of years ago that I wasn't involved with, but I thought was really fascinating, where first they interviewed patients and then they interviewed doctors and gave them the same exact specific scenarios about healthcare, trying to get people interested in quality. And what they found was the reaction of the patients and the physicians were totally different. The patients' reactions when they were being encouraged, for example, to look at quality measures to decide where to go to deliver a baby, the reaction was, why would I want to do that? I would just ask my neighbor. And in the case of the physician, the reaction was, why would I do that? Why would I even want to take this patient? Because he or she is going to be litigious if they're out there looking at quality measures and trying to steer me to a particular hospital. They were not only resistant to quality, but they were on a different page. So there's a lot of education and activity that needs to go on. Now, I will note that, as mentioned in the primer and elsewhere, the new generations of models that are coming out are getting much better at that. They're trying to think of ways to encourage and involve patients. So I think that it's important to keep in mind that this may be a little bit of a dated comment, but it's something still to keep in mind because it's easy when people get focused on all the tough technical things to do to leave the consumer out of it. One of the important pieces that needs to be part of all of this is to ask the question, what do patients really want to achieve? And when designing goals, for example, for complex care, let's say post-acute care, it's very important to know what the patient wants to achieve. I can give you a personal example. When my husband was first out of the hospital and on home health after a stroke where he couldn't read numbers and he was very confused about a lot of things, he had a therapist who insisted that he needed to learn how to dial a telephone. And I kept telling her, no, he doesn't really need to do that. All he needs to do is push this button because we have technological advance that allows him to just push this button. But nonetheless, she was bound and determined that he was going to dial the telephone. And after about 5 sessions, we essentially told her she didn't need to come back. But she never asked him what he wanted to achieve, and there were plenty of things that he could have achieved that she could have helped him with in that period of time, rather than the frustrations that he went through. So whether it be to climb a set of stairs, to sleep in your own bed, after if you have health problems, whatever it is, the patient often has a goal, and getting them involved very early on is really important. And finally, it's important that it's an opportunity to build in consumer issues from the very start to make sure that that gets baked into a new healthcare system rather than added on at the last minute. I think this is part of the reason why it takes time to achieve savings, because everybody's adjusting to a new environment. And before we either give up on new innovations, or before we say that they aren't working, we have to make sure that everybody who's involved, physicians, other providers, and the patients are all on board before we really judge whether or not it's been successful. Thank you.
Great. Patrick?
Yeah, so thanks for having me here today. Really appreciate it. And thanks for allowing me to be 2 minutes late. I apologize. I was coming from another speaking engagement. So it's actually a great segue. I think the reason we do this work is the people and the patients and families we serve. I'll hit on some highlights, but at its core, we think we can have a system that achieves better health, smarter spending, and healthier people. And to get there, I do think patients and families have to be at the center of care. We have policy principles we use at CMS. One of them is around patients and families first. So these are the goals that were alluded to just briefly. The President and the Secretary announced in early 2015 that we wanted to move at least 30% of payments by the end of 2016 in alternative payment models where the provider is accountable for quality and total cost of care, such as an ACO or a bundled payment by the end of 2016 and 50% by the end of 2018. Then in March, we actually announced that we reached that goal ahead of schedule, approximately a year ahead of schedule. And that really is a fairly dramatic shift in the delivery system. Lots more to learn on what works and why and what is scalable and expandable, but a major shift in how we think about paying for care. Goal number 2 included value-based purchasing, so includes things like hospital value-based purchasing and other programs that tie payment to quality and or cost. And the goal there was 85% of payments in Medicare with a link to quality and cost. We actually reached that goal ahead of schedule as well. Importantly, this is not just a Medicare issue. It's Medicaid, it's states, it's commercial payers, et cetera. So we launched the Healthcare Payment and Learning and Action Network to try to collaborate across the public and private sector to not only achieve these goals, but ultimately achieve that better care on behalf of patients. We've now got 8 of the 10 largest private payers engaged in this network. We've got over 1,000 providers. We've got consumer and patient organizations, large employers. And really the focus of the work is how do we agree on goals, which we have, agree on payment definitions, which we have, agree on how to report on those, which we're starting to do now, and then maybe most importantly, work on alignment in many of these models. So if we're talking about an ACO, can we agree on basic constructs around risk adjustment or quality measures or attribution models or how patients might do voluntary attribution? So we're doing that work now. This is, I think, a long-term journey, but I think we've got to set up the structure for effective public and private partnership. I was just at the guiding committee, and a number of the folks around the table said, this work they thought was some of the most meaningful public-private partnership work they'd done in a very long time. So that is the goal, to do this in partnership. The Innovation Center, which is folks here today, we're not going to go all through these models. Interestingly, we chose a lot of the same models to highlight. The ACO model, as was said, almost 480 ACOs, serving about almost 9 million beneficiaries now. We do have increasing numbers in risk-bearing arrangements, so 64 now and counting in risk-bearing arrangements. So you're seeing this both in the public and private sector, increasingly prevalent. Pioneer ACO that was alluded to, improved quality, 28 out of 33 quality measures year on year, improved patient experience and lowered cost, so was certified by the actuary. We brought many of the Pioneer ACO components into what's called Medicare Shared Savings Track 3. We also learned from Pioneer it was designed so organizations could exit but nobody could enter. By definition, then, your numbers go down over time. So our models now have a much more flexible construct where people can come in or out in a much more flexible way. Next generation ACO, really building from some of the learnings in Pioneer. We're going to have a couple years of adding ACOs. The first year was actually a very tight application cycle and had 21 come in. They also have opportunities to exit, and others will have opportunities to enter. A few key points. One, patients can voluntarily say, this is my ACO, this is my choice. And then they're in the attributed population, receive enhanced services, and can even receive financial rebates for certain behaviors like staying within network. It rewards quality. All of our models focus on quality first. It has waivers around telehealth, skilled nursing facilities. So we're really trying to enable those provider organizations that are ready to partner with patients in their communities to move to a much more advanced, this can be fully population-based payment, so totally moving away from fee-for-service. So we're excited about this model, which just started in January, and applications are open now for new participants. Comprehensive primary care, I have an update as of 9 a.m. this morning, or 10 a.m. this morning. So this was our first model on this slide that did show decreased hospitalizations, decreased ER visits. We're going to release the next set of results soon. And we announced this morning what we're calling Comprehensive Primary Care Plus, which is really building on what we learned in this model. It's got 2 tracks, and I'll talk more about those. Estimated 20 states and regions, multi-payer, similar to the previous comprehensive primary care model where we'd agree on quality measures and basic approach. Could be 20,000 physicians and clinicians in the model, and 25 million patients. So it is the largest primary care model in U.S. history, and we think very exciting. Track 1 is similar to CPC, but has a couple important changes, like having the financial incentives at the practice level and more real-time delivery of incentives and payments to practices on a monthly basis. Track 2, they can move to population-based payments, so greater than 50% of payments coming from population-based payments and a compensatory reduction in fee-for-service. So it really opens up that practices can deliver care the way they want to, and patients can receive the care when and where they want to, whether it's telehealth or at home or remote monitoring or care management. Sorry to talk about that one a little longer, but exciting, just-in-time delivery from this morning. Independence at home, I'm going to let others talk about, but also incredibly exciting, and I'll let others that know the model better than I speak to that. Bundled payment, which we'll also hear more about. We've actually now got over 1,500 what we call episode initiators. So these are physician groups or hospitals or post-acute care facilities taking on 2-sided risk in 48, in one or more of 48 various episodes. So these are things, everything from surgical conditions like hip and knee replacement to medical diseases that are complex, where we're redesigning the care system, building those connections between hospitals and physicians and post-acute care providers, and early results are promising in terms of improved quality and lower cost, and we're actually working on releasing some more results here as well. That led to our comprehensive care for joint replacement model, which in 67 markets we're saying we're testing. This is how we're going to pay for joint replacement. We want you to improve quality, lower cost, and have better care coordination. It actually includes testing patient-reported outcome measures, so directly hearing from patients about their functional status and outcomes, which we think is incredibly exciting and important. We heard from patients in these type of procedures. So we think an exciting development. I will end on time. Since I have 20 seconds, I'll say a few more sentences. This is, I'm still a practicing physician. This is exciting work. I think we're in exciting times. I think we've made significant progress over the last 3 to 5 years in improving our health system. And collectively, I think, though, we have to view this as a long-term journey. I always want short-term results as well. But we need to continue to evaluate, to learn, and rapid cycle to scale what works. And I think look forward to the rest of the panel and discussion, but exciting times.
Fantastic. Thank you, Patrick. So this is the part of our program where we turn to the on-the-ground perspective. And we're lucky to have with us today 2 gentlemen who are right in the middle of these experiments. And so we're going to hear from them. Before we do that, though, I want to remind anybody who's following us on Twitter that our hashtag is Medicare Demos. You can comment, you can ask questions, which brings us to the point that after Eric and Jim speak, we're going to turn to a Q&A session. For those of you who are in the room, you have 2 options. There are 2 microphones in the room. You are welcome to ask your question at the microphone. You also have green cards in your folder that you can write a question on, and our staff will be around to pick it up. So we have 2 more presentations before we get to the Q&A. So get your questions ready. If you want to start writing questions, feel free to go ahead and do so. If you're watching at home on C-SPAN, you can tweet us your questions. We do take Twitter questions, and we will try to answer as many as we can. Again, the hashtag is Medicare Demos. So now I'm going to turn it over to Eric DeYoung, who's going to talk about his House Calls, Independence at Home program.
Thank you. Can you hear me? Thank you very much. I'm going to start off with a disclosure, which is on my front slide. I just want everyone to know I'm going to be talking about home-based primary care, essentially a house call clinical model of care for frail elders, and how that has kind of led to the IAH Independence at Home model and demonstration program that has been quite successful in the results announced so far. My disclosure is at the bottom of my slide. My presentation does not involve CMS-sponsored analyses. It's my responsibility, and there's no review or verification by them, although hopefully Patrick will be okay with it. Next slide. I'm going to talk first about the patients that we serve. I'd like to do a brief survey of the room and ask how many people in this room have an elder in their life who is sick and has trouble getting to the doctor's office? Just raise your hand. All right, so it looks like more than half the room. So independence at home and home-based primary care is the model of care for those people. 17 years ago, Dr. George Toller and I came to DC, and we decided to set up a clinical model of care for those folks who are sick elders, very frail, and have trouble getting to the office. Essentially a house call program, but more than that, a home-based primary care program that would follow them across all settings. And we'll talk more about the details of that model. We then wanted to look at the effect of that kind of model, a mobile, team-based approach to care in the home, on quality of care, the patient's experience, and ultimately the costs of care, which is, I would say, a secondary outcome. Most importantly, what is the impact on the patient and the family? And we'll talk about some of those results. And then I want to close with talking about what's next. How can allies and policymakers, both here in this room and across the city, help us expand this program? So who are the patients? It's actually a highly targeted clinical service. In contrast to some of the other demos, it actually targets less than 5% of the Medicare population. Roughly 2 million of the Medicare population could be eligible if it was expanded nationwide. In our practice, they age 66 to 110. The 110-year-old just recently passed away. She was actually born on January 1st, 1900. At the beginning of the century. So this is the kind of folks that we take care of. This service, the intervention, is really simple to describe, but hard to execute. And it's interdisciplinary, mobile primary care teams, 24/7 availability across all clinical settings. So it's not just about making house calls. You take care of the patients wherever they are, and you coordinate all services that they need, medical services, social services, subspecialty, transportation, whatever they need. The goal ultimately is to enhance the health and dignity of these frail elders, bring peace of mind to the caregivers and families. Those are the 2 primary goals. A happy side effect of this kind of care is that it has a dramatic impact on per capita Medicare costs, which we'll talk about in a positive way. The Independence at Home model, which was based on home-based primary care systems across the country, allows home-based primary care teams to be scalable. In some ways, that's the major take-home point for the day. The Independence at Home, both demo and payment model, allows it to be scalable. And the reason for that is, we'll talk about more, but these are the main points. There's very strict criteria for eligible patients. You have to be frail, disabled, have had high costs in the past year. And there's a high bar for service quality in the program. You need to have all the resources in place to really take good care of these very complex patients. You only receive savings after you've achieved 5% reduction in per capita Medicare costs. There's no upfront payment to these programs, and there's no payment until you've exceeded, statistically, a greater than 5% reduction. And you have to link the savings to 6 relevant quality metrics. The providers would get 80% of savings beyond that first 5% if they meet all 6 quality metrics. This is a CBO study, but it highlights the focus on the top 5% and why that has such a big impact. The orange at the top on the left is the number of beneficiaries, but they expend nearly 50% of the budget, and this is similar now in the current Medicare and Medicaid populations as well as in commercial payers. But this is the population you focus on to have the greatest impact on costs. I'm going to talk about a patient briefly. This is a 69-year-old who had liver and heart failure, depression, falls, and a lot of caregiver burden. The year before she moved to DC, she had 6 admissions to the hospital in Colorado and Arizona. That's 6 admissions per patient year in health services speak. The daughter moved her mom to a DC zip code in order to gain entry to a home-based primary care IAH program. And for the last 4 years, she's received over 150 house calls, many social services, coordination of aids, a lot of home x-rays, EKGs, echoes, wound care, many urgent visits by our team, had a terminal diagnosis of liver cancer reversed by subspecialty care at the hospital center, had a life-saving radiology procedure where she was actually having massive hemorrhage internally. We thought she was going to die, and we used the hospital high-level, high-tech care to do a kind of last-minute procedure. It actually worked, and she's now been home again for the last 18 months. In the last 4.5 years now, she's had 2 admissions, 0.5 admissions per patient year. She's been 4 years older and 4 years sicker, but has not been in the hospital more than twice, and she had 1 ER visit in 4 years. I have to change this. Just 2 days ago, she actually had another ER visit. So in transparency, I want to say it's 2 ER visits in 2 years. So how does this work? This is a busy slide, but I won't read it all, other than to say the home-based primary care team has to coordinate everything. It's a direct team of people coordinating everything the patient and family need over time until the last day of life. We coordinate routine and urgent visits. Today, actually, from the weekend, we had about 10 unstable patients, and there are nurse practitioners all around DC today making house calls to prevent emergency room visits and keep people at home. We coordinate ER care, subspecialty. We direct the hospital care ourselves so we can manage the discharge back to home. We're available 24/7, as are all the IH programs have to have a 24/7 availability. We manage rehab, hospice, and then the next 6 bullets are just all the things you can do at home. What is really possible? The hospital really is only for intensive care, surgery, procedures, complex level of things. You can do almost everything else at home, from radiology to blood draws to EKGs to echoes to equipment to IV therapy to IV fluids. And as long as you coordinate all those services, you can have a dramatic reduction in costs. This is a quote from Sylvia, the daughter of that patient, about how the house call program saved her mom's life and mine. It restored her faith in the system and gave them encouragement and support every day. And the good days, hours, and moments she has are a result of the passion, excellence, tireless passion, and commitment of those who created the program. And she gave us permission to give her this quote. I'm going to close with some of the results. This is the VA study that came out in 2014. The highest rated program in the VA showed 12% lower costs. A study of our program in 2014 showed similar mortality, a high mortality of both controls and cases, but a 17% reduction. And finally, the Independence at Home Year 1 results. Our Mid-Atlantic Consortium had a 20% per capita cost reduction. That was about $1,000 per patient month, close to $12,000 per patient year. 9 of the 17 programs were paid savings, ranging from 6 to 31% savings, and in year 1, $25 million was saved, and about $12 million was returned to the providers. I'm going to close with just what are the challenges going forward. Finding the skilled workforce is probably the #1 goal. It's very doable. The people are out there, but you have to have a financial model that will support them. You have to build a lot of practice capacity to support these teams, all the other service partners. And then you have to have a health system that will commit to really doing value-based care. Unfortunately, MedStar Health here in DC and the Mid-Atlantic is now building a new team in Baltimore based on the Independence at Home results and both the quality and the cost savings, because they have faith that CMS and other payers will reward this kind of care. So finally, how can you all in this room help? We are working currently with Senate Finance, House Ways and Means, and Energy and Commerce to turn IAH into a national program, a permanent part of Medicare that will be available in all 50 states and DC. And I'm glad to talk with you in the Q&A about how that's going or afterwards. Make sure you link savings to relevant quality metrics for this population, for people who are in their last couple years of life. Their sugar level doesn't really matter that much when they just have a year or two left of life. It has to be within parameters, but you have to make sure it's relevant for the population. And finally, CMS, to their great credit, have been working hard on independence at home to target the right patients who have persistent high cost, use fair and very rigorous criteria for new practices as we roll this out across the country that will preserve the quality and the impact, and then use really good, fully risk-adjusted methods when you do the outcomes analysis so the results are fair to both the government and to the provider. Here's a picture of our team. This is the most important thing that we do, that we have every day, is that this is a team of 20 people who are here in DC who do this work, and finding the right people is the key to success. Thank you.
I just have to say that I had the privilege of sitting in on a team meeting and shadowing George Tyler, who's your partner in crime. And this is the work you kind of hear about. This is team-based approach. It's collaborative. It's using people to do what they do best in different capacities. And if I had someone who was old and sick and impaired in DC, I would be thrilled to give you a call.
Thank you.
Great, so we're going to move now to Jim Garnham, who's going to give us his own perspective from the University of Rochester Medical Center, where they are trying out bundled payments. Jim.
Great, thank you. Well, I appreciate the time to be here this morning or this afternoon. I do want to just level set understandings of what bundled payments are. So in the simplest of terms, it is a single budget for an episode of care. And when we think about episodes of care, we've had a little bit of a definition around that. It starts with, in our case, a inpatient admission, and we call it the anchor admission, and it goes out beyond discharge out to, again, in our case, 90 days. There are options for less time than that, and it includes, if you think about really everything that happens to the patient after they are discharged from the hospital, inpatient, outpatient, physician, nursing home, those kinds of things. And you know, there was a term that was used earlier today about patient centricity, and what Marilyn said was that the patient comes first. And if you think about a patient-centered approach to care, I think first and foremost about bundles, not just because I'm the director of the bundle program, but you know, if you think about somebody has knee replacement surgery, this is how I've conceived it. If I have knee replacement surgery, or if I need knee replacement, I think bundles starts, or the episode starts when I go to my doctor and I say, you know what, the injections aren't working anymore, the medication isn't working, and it ends when I get to go back to golfing, and now I have a better excuse for how bad I golf. But that's the totality, for me, that's the concept of what knee replacement is. And that's how patients think about it. But it's not how we deliver it, it's not how we finance it, it's not how we pay for it. So I'm very excited to be part of this program because I think it very much is a much more patient-centered viewpoint. So as you can understand, that if we're at risk for all of that care, then there's a huge incentive for us to reduce unnecessary care and reduce unwarranted variations. So that's what we started with. We started with, do we have volumes here that would indicate that it's worth doing, and do we have variations that would say that there is something that we can do to reduce that variation, standardize care, improve care, and reduce cost. But while this is a financial arrangement and it's a contracting arrangement, and that's why I'm involved, ultimately, first and foremost, this is a clinical practice. It is a clinical program. And so we had to go to them. We took the data, which was all great, and we went to the leads of our service lines and said, look, here's some opportunities. Here's some potential opportunities for us to improve care, reduce cost, and really dip our toe into value-based payment. What would you do differently? What would you do to go after this opportunity? What resources would you need? How much would it cost? How quickly could you get there? And what kind of outcomes do you think you could achieve? And that really then, not only did it give us, do we think we can actually get this done? Do we have the clinical knowledge to get this done? But ultimately, do we have the clinical leadership that can actually get it there? So this brought us then down to the major joint replacement as one opportunity, and then congestive heart failure as the other. And you'll see these are very, very different programs. So this is just a little bit of the data that we've started with. This is our baseline data, some of it. And each vertical line is an episode, and the colors indicate where the dollars are being spent. And it doesn't take a rocket scientist to figure out, gee, green is probably where we need to focus. And for major joint replacement, it's skilled nursing facility-based rehab. We started out with 74% of our patients were going home with skilled nursing facility, or to a skilled nursing facility for their rehab. And we said, you know, we can probably do better than that. We can get it down to 25%, we think, within a year. Congestive heart failure, completely different story. There is some skilled nursing facility, but again, I look at that and I go, what's red, and how can we eliminate it? And red is readmissions. The whole thing about congestive heart failure is keeping people from coming back. And if any of you have anybody in your life that has congestive heart failure, you know this constant revolving door. So, all right, so we've nailed down what the objectives are. Now we've got to have a plan to get there. And so we start, obviously, with the inpatient side. The hospital's the one at risk. We have the right folks in the room. But this is not just about improving care in the hospital and then handing it over to the post-acute side. So we actually brought the post-acute folks into the facility and said, look, work with us. Help us understand these patients. Help us figure out not only what we do here, but also what you do on the post-acute side. And let's coordinate and let's have a unified plan of care across this continuum. And then we need once we figure that out, we need a place or a way that we can keep track of those folks across that continuum. So we have a couple of resources. One is a dashboard, which is really simply just a place to put people in. It's a software package, and we can keep track of people. But the real key is the care navigator. One person who has specific focus and responsibility to watch these folks across the continuum of care, not just in, okay, here we're done over at the hospital, here you go, but it's continuing that process all the way through the end so that they're a single point of contact both for patients and for providers. And then the other major resource we applied was enhanced home care. For joint replacement, clearly it was getting rehab done in the home with home care and not in a SNF. For congestive heart failure, totally different approach. It's all about applying those home care resources in a rapid environment so that instead of picking up the phone and calling for an ambulance and going to the ED and back up to the hospital, it's you call the nurse navigator or the visiting nurse service and say, come out and do an assessment, and they can actually bring telemedicine resources so we can do a consult with cardiology on site and even administer IV medications if that's what's necessary to keep folks from coming back into the hospital. So results, we all care about results, right? So this is major joint replacement. Green line is SNF rehab. You see there was 74% at baseline. We set a target for 25%, we've already blown through that. But that's not enough, because we want to make sure that we're not doing that and then people are coming back into the ED or back into the hospital because instead of being in a SNF where they're getting good care, they're at home and maybe they're not getting the care they need. Our ED visit rate actually went down. So not only did it not go up, the ED rate went down. So we're very encouraged by that. And we did bend the cost curve. We did achieve what we were looking for. We think we can do better. Congestive heart failure, completely different population. We have not bent the cost curve. We have not yet really solved the readmission problem, but there is one shining star in this. Because remember, we said we had this clinical pathway, and part of that was home care, enhanced home care services to this population. And so if we look at just the population that went home, didn't go to a SNF, the people that went home with no home care, which means they were offered and they refused it, they came back at least 40% of the time, 47% of the time, they came back at least once. If they went home with a home care agency that was not one of our partners, they came back 43% of the time. If they went home with our partner home care agency that was committed to applying those rapid resources and doing telemedicine and IV Lasix administration, the medication we use to control fluid retention, 17% of the time they came back. So there's a glimmer of hope here, and I think if we just keep focusing on that model, I think we'll do better. So, and I just want to, in the 30 seconds I have left, I want to just say there's one piece of this that I'm really excited about, and the sort of the spillover effects and the lessons learned, and that is, and you would expect the clinical leaders would all be about, hey, let's apply these resources, these great resources, to more than just the Medicare bundled payment folks. And so we've had that, and we expect that. What I didn't expect is I have just as much attention from the administration of the hospital saying, how can we leverage this to other patients, we have a unique opportunity here to really improve the quality of care that we're delivering, reduce the cost that we're delivering. How can we figure out a way to afford this to broaden it out to other populations? That's a really exciting place for a policy wonk like me to be, because usually you're trying to drag along the culture, and instead I'm seeing the culture change before our eyes. So I'll end with that, and we'll take questions.
Great. Well, thank you for that very, very specific information about these on-the-ground programs. It's incredibly helpful. So we are now open for questions. I invite folks who are in the room to come up to the microphone. I invite anybody who would prefer to write a question on the green card, and our staff will be around to pick up your questions and bring them to us. If you are at home watching this live on C-SPAN, you please tweet a question. Anybody in the room can also tweet a question. Again, the hashtag is Medicare Demos. So while we're getting folks set with their questions, I'm going to turn it over to Tricia to kick us off.
I think I have this is a question for Patrick, which we did some work a few years ago that looked at people who live in nursing homes. So people on Medicare who have very high rates of emergency room use. They go in and out of the hospital. They're high Medicare spenders, even though we don't think of Medicare as a place for Medicare spending for nursing home residents. I think there may be two demonstrations, a new one and an older one. Could you tell us a little bit about how they're moving and what the early evidence might be?
Yeah, there are two. So they're both managed by the Innovation Center and our duals office that was alluded to, focused on beneficiaries in Medicare and Medicaid. The first was around evidence-based practices and implementing those to decrease admissions and readmissions. We did see early evidence of a decrease of admissions and readmissions and higher quality, but early in that program. Then we overlaid a financial incentive on top of that model, so to really reward financially as well if we were able to prevent admissions and readmissions. So this is a population that we care about deeply, and two models that have not been certified for expansion yet, but the early results are promising.
Great. So let's move to the microphones.
I'm Dr. Caroline Poplin. I'm a primary care physician. I have a specific question for Dr. DeJong and then a more general question. The specific question for Dr. DeJong is home health visits. My understanding is that Congress has been cutting the amount of money for home health because they think there's a lot of fraud in the program. The fraud that I have seen, because I'm also an attorney, is for-profit home health care provided to people who don't need it while avoiding the people who do need it because it's expensive. My question for the panel is, along the lines of Marilyn Moon, is value for whom? I know value is supposed to be quality over cost, but are the patients involved in the quality measures? And I don't mean patient satisfaction surveys, because for a healthy patient, that's parking and ability to schedule and to call the doctor at night. And for a sick person, it's time with the doctor to ask all the questions and get the explanations and get some empathy.
Yeah, so I heard two questions there. One is just about kind of home health care. The medical house call home-based primary care model taps into skilled home health care as needed, and we have found many very good, ethical, high-integrity home health care agencies that we work with. We use them when we need them for episodes of care, but they're part of the team in the IEH model. And then, in terms of, could you just restate your second question?
The second question has to do with value. When we talk about substituting value for volume, I guess you're talking about quality over cost, but value to whom?
Yeah, well, so
Value
at
to
least
the
my
system?
perspective, and Independence at Home looks at this as well, as value to the patient and family in terms of their goals, their outcomes. In fact, one of the 6 metrics in Independence at Home that's directly linked to savings is whether the patient and family's goals and preferences for end-of-life care are documented, whether they receive a house call within 48 hours of going home. So it's value for the patient and family first, and then value for the payer in terms of being able to afford the care. I think it has to be both.
But I'd like to hear Dr. Conway address it, or some of these other people who are involved in the program, setting them up, setting the quality measures, whether patients are involved in the quality measures. I mean, frankly, I don't care how many mammograms my doctor has ordered.
I think you're making a good point, and I think one of the things that makes most sense to me when you look at these models is to think about whether or not there's actually both flexibility and coordination that goes on, because then you are talking to the patient and you are getting involved in what the patient wants. And it seems to me that in terms of achieving those goals, the kinds of things that we were hearing about, both in terms of the bundle payment and the independence at home, have a better opportunity to do that than ones that are really focused on, are more technically focused and don't involve the patients as much.
And we do have patients on the various quality measure development teams and committees that review quality measures for implementation in various programs. It is critical.
So let's move to the other side here. If you could please identify yourself.
Hi, I'm Joanne Lynn from the Altarum Institute Center for Elder Care and Advanced Illness. I'm delighted that we're on this journey. I feel like we're sort of Lewis and Clark in their first winter, knowing where they're headed, sort of, but having no idea how far away it is and what they will encounter. But I think that really continuing to work on what it is we're trying to get to is an important part of the endeavor, because some of what we are now doing may make it harder to get to where we hope to go. And in that light, let me invite folks to weigh in some on where it is we're going. We talk about total costs of care as if that's an obvious idea. We're only talking about total costs of care in Medicare. The big issue is long-term services and supports, and especially family caregivers. So when we cut out all those SNF days, and we're terribly proud of it, and we're sharing our profits with the providers, we forget that that means that some families have to take people home much sicker, still with their wound clips in, still unable to do a two-person transfer, and someone's got to cope with that. Someone loses work. The caregiver, the average woman family caregiver, loses $250,000 toward her own retirement by taking care of her mother. That's big, but we don't account for that. The big issue is not, it's a big enough issue, just what we're going to do within Medicare, but Medicare has this huge kind of semi-permeable barrier with long-term services and supports, and it's even bigger, especially if you start counting family caregiving. And if we start counting quality measures in that arena, we get into things like people not wanting to be bankrupt, not wanting to lose the ranch, not wanting to be a burden on their kids or their grandkids. It seems that the vision, like Lewis and Clark trying to imagine the Pacific, has to include some real end point that isn't just paying providers for doing what they ought to have been doing 20 years ago. Eric and George started their effort 20 years ago. We knew then what we needed to do. It seems that we really have to start kind of planning these modifications in light of where we hope to get to. And that, it seems, might require thinking in terms of small localities, at least for these very sick people. It doesn't matter
Do you
whether...
have are you building
Yes.
to a question? Or?
I want them to weigh in on whether this seems
Okay.
to be where we're going.
Great.
That one of the directions for a movement would be to really take account of the seriously disabled, seriously frail elders in a geographic community and build the capacity more broadly there. Much of what we're now doing makes that harder to do because we're building financing and quality measure lines that do not support that endeavor.
Okay, let's see if we can get a reaction from the panel here. Anybody?
I can actually take a little bit of that. And you bring up a really good point, and I think it deserves a lot more than I have the time to address today. But let me just give you just a small sliver of what we're doing. So we don't simply turn people over to their home and say, here you go, good luck to you. it actually starts well before the surgery when we're talking about joint replacement. We actually go out to the home, meet with that person, meet with their caregiver, and plan their discharge with them and their caregiver jointly. So it is not just our decision to say, you're going to go home and not to a SNF. It's a joint decision with the patient and their caregiver and the provider. So, you know, you're absolutely right. We can't just kick people home and expect that the family's going to pick up the slack.
Great, let's move to the other mic here. Oh, did you have a comment, Patrick?
We obviously talk a lot, so I won't give a long answer. But, you know, I think we're trying through accountable health communities, through some of our Medicaid transformation work, including on long-term services and supports, and some of our state innovation work to start to address more of these issues and the holistic care paradigm, including out of the provider system, and really testing models at the community level to improve health and health outcomes. You know, I think it's a fair point that we have more learning to do in this arena about how to do that the best way possible.
Okay, great. So thank you. Let's move to this microphone.
Thank you. My name is Amy Gibson. I'm with the Patient-Centered Primary Care Collaborative. I want to build on some of the comments, Marilyn, you were making about how we get buy-in and why buy-in among patients is so critically important. And one of the things that we've come to realize is you really need to have them involved as partners in the design of the program from the very beginning. We just heard from a panel of patients in a conference in Chicago from a patient who reminded us that quality is assumed by patients. So when they're going to get advice on where to go to get their best care, they're not necessarily looking for a 4 or 5 star rating that shows them that the quality is good, but rather, as you address, that they're going to their friends to find out, did your doctor really listen to you? What was your experience in care? So I think if we have the conversation with patients around improving experience of care, and they also absolutely understand value of care. Dr. Conway, I certainly want to first and foremost applaud CMS for all that you've done to demonstrate how important those collaborations are from the very beginning. I mean, our organization is funded as a support and alignment network within TCPI specifically to facilitate these collaborations and meaningful partners with patients and families and clinical redesign. Dr. Conway, I just want to kind of have you talk about that and some of your learnings and how CMS is starting to evolve those relationships, and even through the expansion of programs that are successful and new programs that you're developing. What are you doing to better assure that there is that collaboration, meaningful partnership with patients from the very beginning?
Yeah, so thank you for the question. It is a critically important issue. So a few things we're trying to do. One, which was talked about earlier in the sort of quality measures and what's the quality focus. We think patients and caregivers are the most important voice in that equation. Two, and I think we're doing this now, and I appreciate the positive comments. I think we need to continue to do it better. How do you engage patients and families really in the design, as you said, and the life cycle of the model? And I think this is something we've met with a number of groups thinking through this and how to do it more systematically. So stay tuned for even more, but I think we agree with the concept that you want patients, people, consumers, families, and caregivers, to use all terms, to be as inclusive as possible, to help design these models, truly be co-creators, both at the start through the evolution of the model as we try to improve models, and in aspects of evaluation, such as the quality measures in the model.
Great, thank you.
Great. So let's move to a question from one of our green cards.
We actually have a few questions on the issue of how well does all of this work in rural areas? So several of the demonstrations we've heard about are sort of well suited for areas where there's a concentration of people and providers. I think there's a story in the paper this morning about some of the challenges that people in rural areas face, especially seniors. I think a quarter of all people in Medicare are living in rural areas. So this is really for anybody in the panel. We've talked about scaling up things that work. Do they work in rural areas?
Yeah, this is Eric DeYoung. So I think independence at home and home-based primary care can work in every state in the country, rural, suburban, and urban. The challenge will be how do you staff it? In Arizona and kind of New Mexico, there's a IH-like kind of home-based primary care program that uses more tele-video, uses slightly different staffing. The doctors are sometimes more consultants, but you can achieve the same goals of keeping people at home, using mobile technology, and kind of with a slightly different kind of staffing mix. but I think this can be done in any geography.
Yeah, just building on that briefly, and then others. You know, this is an issue we focus on significantly. I think the primary care models and independence at home can be done in rural areas. We did advanced payment and other methods, which in our ACO program, which had the vast majority in the last round of participants were small practices or rural practices to help with the transformation work. We also are engaging with a number of states that are thinking about population-based payments for rural areas and what that might look like. So I think more work to be done, but a number of these models can work successfully in rural areas, and then it's how do you make that even more common?
Okay, yes, at the mic.
My name is Jenny Boyer. I'm with the HealthNet Federal Services. We're the contractor that manages TRICARE in the Northeast.
You can just pull the mic a little bit closer.
Sure. So my question, especially to those of you who are involved in making policy, all the pilots are great when it's a well-known and high-quality facility for a small area, but how do you scale that for the whole country, and what happens when the quality inevitably deteriorates? So.
I think that might be for me again. So a few thoughts. One, you know, the majority of our pilots are voluntary, either community, state, or provider pilots. You are seeing a number now, like the joint replacement, which are testing in a geographic area, including all providers in a geographic area. The sequence there was we saw early positive results in the joint replacement model from the BPCI, the bundles model that was talked about. Now we're testing a geographic area to learn what you just described. Will the results be the same in a diversity of providers? We do have monitoring. We're trying to minimize unintended negative consequences and try to eliminate them if possible. So we have monitoring. We have the ability to pull people out of models. We have other tools we use when we have major issues. But I think you need an array of testing strategies. You've picked up a lot of the early adopters, and now we're moving to the big middle, and we're sort of shifting the curve, as was alluded to. So it's, you know, how do we now learn in this sort of big middle of transformation, and what works with the big middle, if you will? You know, how does context, sorry to answer longly, I'll try to be brief. It's a good question, though. Context of the providers really matter, et cetera. And so we're trying to structure this now in a sort of stepwise progression that picks up an increasing number of states, communities, and providers across the country, including ones that maybe historically weren't high performers, but want to be high performers in a population health construct. And lastly, supporting people. So we're making major investments through transforming clinical practice, which was alluded to, and other initiatives to support various providers, states, and communities to improve.
Marilyn, could I just add that I think that not only do you see in the beginning the high performers, but you often see the highly motivated and ready to change folks. And it's the not so ready to change people that you're worried about then bringing these to. So then I'm glad to see Dr. Conway talking about the importance of then providing additional resources and providing education and information to people, because the leaders already are motivated to change in many cases, and it's the folks who are just not sure that's what they want to do or are skeptical that you need to bring along. And I think that is a really important aspect of the next stage of all of this.
Okay. Thank you very much.
Great, we have another question at the mic.
Hi, I'm Carl Polzer, from co-chair of the Long-Term Care Discussion Group, and I really enjoyed the presentation about the Independence at Home program and the savings to Medicare and the quality of the care. But this is, I thought of this question before the other two questions, but it's sort of a follow-up. What do we really know about the incidence of long-term care, Medicaid costs, and the burden of unpaid caregiving around? And if you don't have specific studies, what's your sense? Does it also save assisted living, nursing home, and home care, long-term care services, or doesn't it? And what about the needs, the pull on the home, the unpaid caregiver?
Sure, thank you. So in our practice here in DC, we have a less than 5% incidence of nursing home placement per year, so about 95% plus of our patients stay at home long term. and that's much lower than kind of the benchmark around the country for this population. We haven't done the Medicaid cost analysis. There's actually a number of, both at Penn and I know within CMS, some interest in doing that. Our experience is if you have social workers on the team, as we do, and you have the true interdisciplinary approach and get the care for the caregivers and the patient in place, the kind of amount of both nursing home placement and then therefore Medicaid costs is significantly less.
Do you want to ask this one?
I'm afraid this one might be for Dr. Conway too, but maybe anybody else want to join in, that would be terrific. Everyone, including presidential candidates, is talking lately about the problem of rising drug costs. How will these demos address the problem, and are there any particular demos that directly address this issue? And I think I know from where you were speaking this morning that you have a specific demonstration to talk about.
Yeah, so a number of the models, before I talk about the specific one, do include drug cost, typically B costs, but next generation even includes the possibility of organizations bringing in D costs. Our oncology care model, which we had a robust interest in, we look forward to announcing the participants, also includes both A and B costs, so includes drugs. We do have a Part B model, which I spoke this morning about at Pew, that directly focuses on paying for value and better patient outcomes in Part B. I want to say clearly it does not limit access. We do not believe that the proposal limits access for any patient to get any drug they need and any physician to prescribe any drug that they think is warranted. If there are examples that people can provide that around limiting access, we would want to know about those, because access and focusing on better patient outcomes is a core principle for us. But we do think the Part B model is a proposal that we're seeking comment on that could directly be aligned with paying for value in the drug arena.
Great. We have another question at the mic.
Sure. Hi, this is Christine Grossman. I'm with the Alliance for Specialty Medicine. I actually had a question. Hi, Patrick. I had a question actually for Jim. I used to work at CMS actually up until quite recently. I had a question on your bundled payments portion. So you talk about the episode of care lasting until 90 days post services. And I wanted to know, I've heard of several docs, both, now and in my previous position in the past at CMS, having issues in terms of following up with patients and getting information past 90 days. So I wanted to see if you all account for that and, what you do in terms of if a patient doesn't follow up and how that computes into bundled care.
Yeah, patient follow-up is a huge issue for us, particularly for the congestive heart failure. I'll tell you a little bit of a story, and this is only tongue-in-cheek. One of the medical directors of the congestive heart failure program said that if he could find a way to combine the oral Lasix medication, which is the drug we use for fluid retention, with crack, then we could get our patients to be compliant. And he was only half kidding. So when you talk about patient follow-up, I mean, we have care navigators that are constantly calling and visiting folks to try and get them to come into those follow-ups, which is one of the reasons why we have initiated telehealth services through the visiting nurse service. So if they can't get back to the clinic for their follow-up appointment, we'll go to them, and so they can have that visit wherever they happen to be. But patient follow-up is one of the hardest things to do in this population.
Thanks.
Yep.
Okay, thank you. So to follow on that, let's talk about additional implications for patient involvement. So there are some pros and cons associated with passive enrollment in these models of care. So what are the implications of more or less patient beneficiary involvement?
I can comment a little bit more as an analyst, looking a bit, like you said, at the pros and cons. I'd say on the, and while some models are being introduced in the future that allow more patient engagement, some of the ones that we have results about now have more of the passive attribution, which you note. And I think some of the thoughts behind that are that in the one hand, it's not very disruptive to the patients. This is going behind the scenes through claims-based analysis. And then it in fact places a greater role for the providers to really engage the patients and work on the care. And also it eliminates some of the selection issues that I think Marilyn sort of brought up, where, although this is more the patient selection, where patients, whether they be recruited or not recruited. So some of the passive enrollment from an analyst perspective has some merit. But on the other hand, you're losing, by this passive attribution, you're losing patients volunteering to be part of this model and then being more proactive in listening to the care decisions and making choices about which providers might in fact be higher quality, lower cost. So I think there is a push and pull, and I imagine that the future models that are coming are going to be assessing both that push and pull about selection issues versus patient engagement and patient involvement.
Just gotta say one, and for some it could be both. That there's both passive populations plus active choice populations on top. And so we do want to learn how to do this best and what's the sort of deepest level of patient engagement necessary. And I think just to build on the answer, which I agree with, in some models it may be both.
So I want to note, we still have 15 minutes or so to go through, to get through more questions, but I want to point out that in your packets you have a blue evaluation sheet, and we would be very grateful if you would take a moment to fill it out. We've actually made it a little bit shorter so it's easier to fill out, so we'd be grateful if you did that, but this is not an invitation to leave. So I would actually like to ask Patrick and the others up on the dais to look into the crystal ball, into the future, into the next year, into the next 2 years, to give us an idea of what's coming next, whether it be expansion of some of the programs that we're already seeing in demonstration projects, whether we're expecting to see some new kinds of programs that are bubbling up that aren't necessarily part of the demos, but they're starting to come about in the private sector. What will be the focus? What do you all see coming down the road if we look ahead?
I can start on this and others. So, great question. First, at a high level, I think I actually see the level of transformation accelerating, and my prediction is that may continue in a positive direction. I think I'm seeing a cultural shift. 3 or 4 years ago, I talked to a big group of CEOs about this, and I could tell it was like, yeah, that may happen someday, but not that worried about it, including a very tangible example where the person told me, I'll never be in one of your models, and now they're in a bunch of our models. And it's because, I think you've seen a cultural shift that people know this is where we're going, it's the path we're on, we need to learn how to get there. So I think the progress will continue regardless. Delivery system reform, I think, is truly bipartisan. Then on the details, I'd call out 3 main things. I think you will see increasing, we announced the certification of the diabetes prevention program, which we haven't talked about today, a few weeks ago. I think you're going to see increasingly results that meet the bar for expansion and therefore expanded in the program. You're also going to see us take learnings from programs, even if it's not formal expansion, and propose them into various programs. 2, I think you will see continued models that fill gaps, like the Comprehensive Primary Care Plus model today. We're actually working on some direct consumer-oriented models that are really complicated and hard to get right, but we're working on, we've worked on health plan innovation, which we haven't talked about much today. The drug space, you have the Part B model, it's a proposal, so I think you'll see gap filling. And then 3, I think this private sector public partnership aspects you're going to see accelerate. Increasingly, when I interact with private payers and states and Medicaid programs, there's agreement on this is where we need to go. There's actually agreement on a lot of the high-level payment models. So I think you'll see a shift across the public and private sector, which actually will make it, I've been on the provider side and had to deal with various makes it much easier to succeed if you're getting a common signal, across your payers, from your state, et cetera, about moving to this alternative payment world.
I'd like to talk about consumers from two perspectives and how this will affect things. I think the argument for increasing impetus for change comes from the demographics of the baby boom population turning 65, much more accustomed to questioning authority, much more accustomed to being skeptical about being told something by a physician, for example. And with all of the attention and publicity around change, I think recognizing that change is not only going to be coming, but that if people want to have a role in it, they need to be fairly active. On the passive side, or on the more troubling side, we will have an increasing population of diverse people on Medicare program than we do now, as increasingly the number of Latinos and African Americans increase as a share of the population on Medicare. That increased diversity means that you have a bit more of a challenge in reaching out to those people who have different cultural backgrounds, particularly on the Hispanic side, where we know from a lot of research that people behave differently, respond differently, interact with the healthcare providers differently. And that's going to mean that unless we reach out and really try to provide good outreach and education, then there'll be some problems there. So it can be on the one hand, on the other hand, I guess. But I think there'll be some positive things, and there'll be some additional remedial work that needs to be done.
I'll add one more change that I feel like I see that has come up here and come up on the panel, which is about health workforce. And I see that changing a bit, where we have the navigator with the bundling that is mentioning in Rochester, and we have community health workers involved in hospitals and in the paper today. So, and I think, and in the rural areas, which came up as a question, there's different workforce models that I think may have the ability to coordinate care across settings even better. And I think that might go hand in hand if the payment incentives continue to find ways to marry those. And so the workforce, but that needs to be cultured. There's other systems to develop that.
I have a question, which is, we're talking about changes in traditional Medicare and really learning from different models in order to improve the way care is provided. I'm wondering how all of this relates to what's going on in the Medicare Advantage world, and whether or not some of the lessons learned from Medicare Advantage are being applied into traditional Medicare, and conversely, are the things that are working in traditional Medicare being injected into the Medicare Advantage space, and how would a beneficiary know?
Yeah, so I'll start, others can jump in. So we are having this bidirectional learning and approaches, and then I'll describe briefly further. So one, there's examples of models, for example, value-based insurance design, which we launched in Medicare Advantage. We had seen much of that work from the private market. So it's bringing those learnings and then testing them in the Medicare Advantage market. I interact routinely, as do many of us, with the Medicare Advantage, their various clinical quality and innovation leaders. So we're learning from them on some of the consumer-oriented work they're doing as well. I think likewise, we've had examples in ACOs, bundles, independence at home, primary care, where we're sharing directly what we're doing with other payers, encouraging them, because often we can encourage but not require, which is appropriate, and encouraging the various Medicare Advantage plans to adopt or consider adopting these various new payment models, and we're seeing that happen. So I think you're going to see the way that Medicare Advantage plans pay providers and traditional Medicare pay providers, I think, increasingly converge over time.
So just as a quick follow-up, for something like Independence at Home, which is focused on the frailest, high-cost people who are living in the community, is that something that is a part of the care system that Medicare Advantage plans are providing, as far as you know? and is CMS working with Medicare Advantage plans to be sure that these best practices, if they are best practices, are being replicated for beneficiaries no matter which delivery system they choose?
Can I just mention that actually Medicare Advantage companies are taking up independence at home model, home-based primary care, and there's in multiple states, both New York and Oregon already, programs are having contracts with Medicare Advantage companies to be paid under a per member per month that covers the costs of the program and gets them into the black, and they're now doing that care as we speak.
Okay, great. Oh, go ahead.
Comprehensive Primary Care Plus, which we announced today, we'd want Medicare Advantage plans, we'd want Medicaid plans, we'd want commercial plans at the table.
Great. Question at the mic?
Hi, I'm Marion Grant, the Policy Director of the Coalition to Transform Advanced Care. These models are great, and hopefully they will continue to be successful, but how will we coordinate these models into the future? So if you're a frail elder who needs a hip replacement, are you in an ACO, but you're also part of Independence at Home, and then it's a bundled payment? Can you speak? And I know that the demos are individual projects, which they need to be from an evaluation standpoint, but how's it gonna come together?
I'll just say, from the doc perspective on the ground, I think that the patient population has to drive the financial models, the payment models, and not vice versa. So you have a lot of silos of all these different financial models, but ultimately, in our program, we take care of the patient from day one until the day their last day of life, and all of that care for now is within Independence at Home. We right now are not in an ACO because they're right now mutually exclusive, and we don't participate in bundles either because that would kind of interfere with the shared savings model. So for right now, IAH is a standalone, all the way, fully coordinated program, and that's the way I think for now it needs to work.
And we have other examples, like you can be a bundled payment entity plus an ACO, and then we have mechanisms on the back end, if you will, to ensure we're not double paying, but also align the incentives across programs. And we'll continue to work on those issues.
But I would just say I think that what we're going to find is, as some of these things fall out and we really find financial mechanisms that are working, they will become the industry standard for how care is paid for and organized. And so we're going to have to work through those issues. But I mean, we did this, 20, 30 years ago with DRGs. The hospitals stopped billing for every little bit, and we bundled the care together in that. And now Medicare did that, Medicare started that, and the rest of the industry fell in line. And I think we're going to find that as well with these models.
But I think we're going to need some help for consumers for a long time to come. And the whole idea almost of ombudsman or support is really important. And there's an area where I think you also have to worry about the relationship between Medicare and long-term care type, long-term supports and services. And in fact, I think one of the things that would be good for Medicare to be able to do over time is to provide not only some of those ombudsman kinds of services, but potentially even a structure to help people manage the long-term services. That might be an add-on program that people would enroll in and pay a modest, let's say, income-related payment for, in which they could get additional help in managing that system. But I think the whole idea of managing it, to think of managing it by yourself if you're sick is pretty scary, even if you're managing it with the help of a family member. So I think that's an area where we really need to think about maybe even a model unto itself in terms of an innovation.
So I think we are wrapping up because while we do have more questions, I don't think we can get to all of our questions. I want to thank the Alliance for this really interesting discussion and the panelists. I want to give a plug for our primer, which at least two of our panelists worked on, Marilyn and Tricia Newman. If you haven't learned everything you needed to know about payment delivery system reforms under Medicare, here's your cheat sheet right here. So I want to thank you and thank Marilyn and everyone else.
So for those in the room, you have that in your packet. For those not in the room, you can find that at our website, www.allhealth.org. Please join me in thanking our panelists for a really exciting conversation. And one more plug to please fill out the shortened, streamlined evaluation form. Thank you very much.
Yet another improvement.
Barbara, question. Hey, Alan.